everyone, welcome to TryRight. This is Pack 365, myself Srija. Today in this session, you're going to learn about CPT coding guidelines for surgery of cardiovascular system. So you're going to learn how the cardiovascular system section is organized in the CPT codebook and how to read it correctly. So the cardiovascular system, it includes procedures done on the heart, blood vessels, blood, lymphatic system, mediastinum and diaphragm. So the CPT codes for the system range under 33,016 to 37,799. So what are the headings and subheadings? So what does this mean? So CPT is not just a list of codes, it is divided into sections, subsections and subheadings. So each subsection has its own rules, notes and guidelines. So what are asterisks? So asterisk, this means these are a special coding instructions. So you must read the guidelines before selecting a code. For example, there are arteries and veins here. So the code category is 34,001 to 37,799. So this section has many bundle services, add-on codes and imaging rules. So CPT gives extra guidance. So notes and guidelines come before the codes. So guidelines may tell you what is included in a procedure, what can be reported separately, and when modifiers are allowed, when imaging is bundled, and when add-on codes must be used. So you have to always read guidelines before choosing a CPT code. And why CPT does this? Because CPT groups codes by anatomy and procedure type, not strictly by the number order. So you may see a code range repeated, a higher code number appearing before a lower one. So this is very normal and intentional. So coming to the subsections of the cardiovascular system. So what are those? The first subsection is heart and pericardium. The code range is 33,016 to 33,999. So this covers procedures involving the heart chambers, valves and pericardium. So pericardium is a sac which is present around the heart. So the examples under this section is pericardiocentesis, cardiac catheterization, pacemaker and ICD procedures. So next section is arteries and veins. So the code ranges are 34,001 to 37,799. So this is the largest and most complex subsection. So it covers the open procedures, endovascular procedures, angioplasty, stents, atherectomy, bypass grafts and repair of the aneurysms. So why this section is very tricky? Because it consists of many bundle services. Imaging is often included and add-on codes are common. So next section is hemic and lymphatic systems. The code range is 38,100 to 38,999. So this deals with the blood forming organs, lymph nodes and lymph vessels. So the examples under this section is lymph node biopsy, lymphadenectomy and also some of the splenic procedures. So these procedures listed under this section are often related to the cancer staging and infection. And next is mediastinum and diaphragm. So this covers the mediastinum. So mediastinum, it's a space between the lungs and diaphragm. So the examples of this section are mediastinal mass removal and diaphragmatic repair. So these procedures are anatomically close to the heart, which is why they are grouped here. So what are the learning objects in this session? Cardiac catheterization. So what is cardiac catheterization? It's an insertion of a catheter into the heart chambers or the coronary arteries. So this is used to measure the pressures, check the oxygen levels and to visualize the coronary arteries. So coding focus is always the diagnostic versus the interventional right heart, left heart or combined catheterization and also the bundling rules when done with PCI. So what is PCI? Percutaneous coronary intervention. So what it is? It's a non-open procedure to open block the coronary arteries. So they include the angioplasty, stent placement and atherectomy. So the only focus here is one primary procedure per vessel. So add-on codes for additional vessels and also coronary artery family concept. So you have to apply the concept of coronary artery family. Next is the coronary artery branches, arterial vascular family. So here special CPT rules must apply. So what you will learn here, coronary arteries are grouped into vascular families. For example, into left main artery, left anterior descending artery, LAD, left circumflex artery LCX, right coronary artery RCA. So only one intervention per arterial family is coded as the primary. And diagnostic angiography. So what it is? It's an imaging of the blood vessels using contrast. So when diagnostic angiography is billable, bundled and not separately reportable. So reporting angiography when it was done only to guide intervention is a common error. So it must meet the medical necessity and the decision making criteria. Peripheral intervention overview. So what this covers? It covers the interventions which are done outside the heart, like abdomen, pelvis, upper and lower extremities. So why this section is important? Because it has extensive bundling rules. So add-on codes are common in this section and imaging often included within the code description. So peripheral coding is region based but not vessel by vessel like coronaries, arteries. Next is revascularization of lower extremity. So what does this mean? So revascularization is it's a restoring blood flow to the legs. So the coding focus based upon the iliac arteries, femoral arteries, popliteal arteries, and tibial or peroneal arteries. So here hierarchical coding takes the concept. So highest level intervention counts and lower level interventions are often bundled. So one of the most confusing topics is this revascularization of the lower extremity and procedures angioplasty. So what this means? Angioplasty is a balloon dilation of a narrowed vessels. So the coding rules here will be standalone codes versus bundled codes. So these are often included when the stent is placed and the atherectomy is performed. So if a stent is placed, angioplasty is usually not coded separately. Atherectomy. So it is a removal of plaque from vessel wall and different codes will be there for coronary arteries, peripheral arteries, and these are often bundled with angioplasty. So atherectomy is more complex and it usually takes priority in coding the hierarchy. Next is stent placement. So what it is? It's a placement of metal mesh to keep the vessel open. It focuses the bare metal versus drug-eluting, initial vessels versus additional vessels, and add-on codes. So only one primary stent code per vascular family is coded. Next is pacemaker. So what it does? So pacemaker, it always regulates slow or irregular heart rhythms. So the coding categories include insertion, replacement, removal of the pacemaker, and lead revision of the pacemaker. So coding always depends upon single versus dual chamber and temporary versus permanent dual leads. Implantable cardioverter defibrillator. So what it does? It detects and treats the life-threatening arrhythmias. So the coding focuses upon the insertion versus replacement, generator versus leads, with or without pacemaker function. And last is modifiers. So why modifiers matter here? Cardiovascular procedures, they have the multiple providers, bilateral services, and stage procedures. So what are the common modifiers used? 26 professional, TC technical part, 59 it's a distinct procedural service, and XS, and also multiple procedures like 51 and also 52 reduced, 53 discontinued services. So modifiers can make or break the claim payment. So coming to the first procedure, cardiac catheterization. So what is cardiac catheterization? So it's a procedure where a thin flexible tube called as catheter is inserted through a blood vessel and it is guided to the heart to measure the pressures, to check the oxygen levels, to evaluate the heart chambers and vessels, and also to help to diagnose the heart disease. So it is done to evaluate but not to treat. So what is included in this cardiac catheterization? Introduction or insertion of the catheter, position and repositioning of the catheter, recording intracardiac and or intravascular pressures, and also giving the final evaluation and report. So you do not code these separately, they are bundled into the cardiac catheterization CPT code. So trying to code catheter manipulation or pressure measurement separately. Vascular access. So from the diagram, you can see here the picture. So here the catheter is usually inserted via the femoral artery and radial artery. So it is guided through the blood vessels to the heart. So the contrast dye may be injected to visualize the arteries. So access site does not change the CPT code. And diagnostic versus interventional concept. So there is a diagnostic cardiac catheterization and interventional cardiac catheterization. So diagnostic cardiac catheterization, it involves measures pressures, it evaluates anatomy, it may include coronary angiography, and the CPT code ranges from 93451 to 93461. Whereas interventional cardiac catheterization, it includes angioplasty, stent placement, and atherectomy. So this falls under PCI but not diagnostic catheterization. So there are two cardiac catheterization code families. So what are those? Congenital cardiac catheterization and non-congenital cardiac catheterization. So congenital, coming to the CPT codes are assigned. The code categories are 93593 to 93598. So these are used when a patient has congenital heart disease, the structural heart defects present from the birth. So congenital codes, they are used regardless of the patient age, even in the adults. Non-cardiac catheterization, non-congenital. So the CPT codes ranges from 93451 to 461. So this is used when there is no congenital heart disease, typical adult cardiac conditions like CAD, coronary artery disease, heart failure, and wall disease. So the diagnosis, not the age, it decides which code family to use. So understanding the code range 93451 to 461. So these codes are based upon the right heart catheterization, left heart catheterization, combined right and left. So whether the coronary angiography was performed or not. For example, there is a right heart catheterization only, left heart catheterization with coronary angiography, and combined catheterization with imaging. So these are the circumstances, these are the situations where cardiac catheterization can be evolved. So you must know what chambers were entered and what imaging was done. So in this picture, there's a catheter pathway from insertion site to the heart. So contrast dye highlighted the coronary arteries. So the plaque causing the arterial blockage. So it helps you to visualize why pressure measurements matter here, how angiography works, and what is the difference between diagnostic and interventional codes. So this is about the cardiac catheterization. So next procedure is PCI, percutaneous coronary intervention. So what is PCI? It's a percutaneous coronary intervention. It's a non-open procedure. Non-open means there is no incision. It is done through skin. It's a percutaneous approach. So it's a procedure, non-open procedure performed to treat the blocked coronary arteries. So PCI, it is used for occlusive disease of coronary vessels, for major coronary arteries, for coronary artery branches, and coronary artery bypass grafts. So the PCI CPT code ranges are 92920 to 92944. So these codes, they are used only when an intervention is performed, but not for diagnosis alone. So what are the types of PCI procedures include? Balloon angioplasty, stent placement, atherectomy, and combination procedures. So PCI codes always follow a hierarchy. So they always follow the hierarchy. So more complex procedures include the simpler ones. So you cannot separately code a simpler procedure if a higher one is done. So what is the golden rule for coding PCI? Code only the highest level intervention per vessel. So here you can understand the PCI hierarchy. So this shows the hierarchy from highest to lowest intensity. So 92943, 92941 has highest intensity, which is equal to 92933, 92924, 92937, and the lowest is 92920 here. So what does this PCI procedure visual explanation tells you? So the picture A, it tells you balloon angioplasty, picture B, stent placement, and picture C, atherectomy. So in picture A, the balloon angioplasty, here the balloon inflates to widen the artery. So there is no device left behind. It is very lowest in the hierarchy. Second is stent placement. So metal mesh placed to keep the artery open. Angioplasty is included here. And atherectomy. So plaque is shaved or removed in this case. So it is often combined with stent. So it has the highest intensity. So more work, it gives you the higher code. Higher code, it includes the lesser work. So why coronary vessels matter? So PCI codes apply to major coronary arteries, branches and bypass grafts. So the CPT rule is one primary PCI per coronary artery family. So additional arteries may be coded with add-on codes. So coding multiple PCI codes in the same artery is a common error. PCI versus diagnostic angiography. So what is diagnostic angiography? It may be separately coded only if there is no prior catheterization exists, if it changes the patient management, and it's not just guiding the PCI. Otherwise, it is always bundled into percutaneous coronary intervention. So these PCI codes include the following. So what does it include? What are the services that are bundled into PCI codes? This cannot be coded separately. So the first is accessing point. So maybe the access be femoral or radial artery, the puncture and the sheet placement. So access site work is always included in PCI. And second is selective catheterization of the vessel. So guiding the catheter into the coronary artery, advancing the wire and catheter to the lesion. So do not code the selective coronary catheterization separately with PCI. Transversing the lesion, crossing the blockage with a guide wire, preparing the vessel for angioplasty or stent. So this is included in the PCI. It is not separately billable. Radiological supervision and interpretation. So in these cases, the fluoroscopy used during PCI, the imaging to guide device placement, and the PCI codes already include the imaging guidelines. And the closure of the arteriotomy. So closure device includes angioseal and also perclose. So manual compression is done via the access sheet. So never code these with separately with PCI. And last one is imaging to document completion. So final angiographic images showing vessel patency and also successful stent placement. So these are included in the PCI code. And what are the major coronary arteries? So there are major coronary arteries. So those are left main, left anterior descending artery, left circumflex artery, and in the right side you can see right coronary artery here in the picture, and also the radius intermedius when it is present. So each of these considered the one major coronary artery for coding. So you can see clearly the coronary arteries on this picture. So left coronary artery, circumflex artery, left marginal artery, left anterior descending artery LAD, and diagonal arteries here. In the right side you can see only two, right coronary artery and right marginal artery. So all the PCI procedures performed in all the segments of a single major coronary artery are reported with one code. So what does this mean? If PCI is performed in proximal LAD, mid LAD or distal LAD, left anterior descending artery, so only one PCI code is reported. Only one per session and also per hierarchy. So next is the native coronary circulation versus bypass graft. So native coronary arteries and bypass grafts are coded separately. So each has its own PCI codes. Next procedure is angioplasty. So what is an angioplasty? It's a procedure. It's a procedure used to mechanically widen the narrowed or the blocked arteries. So most commonly due to atherosclerosis, which is a plaque buildup. So angioplasty, it opens the vessel but does not remove the plaque. So if removal of plaque involves, then that's it. It is called as atherectomy, as we discussed before. So why arteries become narrowed? Why? Because by the formation of plaque. So by the formation of plaque, there will be a formation of fat, cholesterol, and also the inflammatory cells. So over time, this plaque narrows the artery and reduces the blood flow. If the blood flow is reduced, it results in the chest pain, heart attack, and limb ischemia. So angioplasty is like flattening a dent in a pipe to restore the flow. And balloon catheter. So balloon catheter, how the procedure works. Here is a step-by-step procedure. So a guide wire is advanced across the blockage first. So next a balloon catheter is passed over the wire, and the balloon, it is inflated at the high pressure, that is 6 to 20 atmosphere. So this is that 75 to 500 times normal blood pressure. So then this plaque is compressed against the vessel wall and the balloon is deflated and removed so that the vessel lumen is wider. It improves the blood flow. So the balloon does not stay in the body. And the blood pressure. So why it's mentioned? So this slide mentions 6 to 20 atmospheres to emphasize how strong the balloon inflation is. So why angioplasty can crack the plaque and stretch the vessel walls. So high pressure can cause the vessel dissection, recoil, which is why stents are often placed. So what happens now to the plaque? Plaque is compressed, but it is not removed. Vessel wall is stretched and it creates a larger channel for the blood flow. So angioplasty is nothing but it compresses the plaque, whereas atherectomy, it removes the plaque. So there is a difference between two procedures. So now what is the role of stents here? So why stents are used within the angioplasty? So the stents, it prevents the vessel recoil, it keeps the artery open in the long term, it reduces the restenosis. So now what are the types of stents here? There may be a rare metal stent, BMS, and drug-eluting stent, DES. So when a stent is placed, angioplasty is bundled, but it is not coded separately. And here is a picture showing you the angioplasty. So in the first step, the balloon is entering the narrowed artery. And the second, the balloon gets inflated with or without stent. And the third picture, it shows the expanded stent. Expanded stent which is left behind after the balloon removal. So how angioplasty is classified in CPT coding? In PCI hierarchy, angioplasty is the lowest level. So if stent or atherectomy is performed, angioplasty is not coded separately. So the common angioplasty related CPT codes are for coronary angioplasty, you have to assign CPT code 9 to 920. And next process is atherectomy. So what is atherectomy? It's a revascularization procedure that widens the narrowed arteries by physically removing the plaque using a specialized catheter tip. So there are types of atherectomy, and what are those? Directional, rotational, orbital, and laser. So directional atherectomy, it cuts the plaque from one side. Rotational atherectomy, it's a diamond burr spins and pulverizes the plaque. Orbital atherectomy, it's in a sanding motion, and laser atherectomy, it vaporizes the plaque. So PTA, it is included with atherectomy. So what does this mean? Balloon angioplasty, it is done before or after the atherectomy. So it is not coded separately. So what is the CPT hierarchy rule? Atherectomy has the highest intensity when compared to stent and angioplasty. So stent placement. So what is stent placement here? A stent is a metal mesh scaffold which is placed in an artery to keep the vessel open to prevent the recoil or collapse after the angioplasty or atherectomy. So the balloon inflates, next the stent expands and then the balloon removed so that stent stays. So PTA included with stent placement. So you never code angioplasty separately if a stent is placed in the same vessel and atherectomy is performed in the same vessel. So here is the image which shows you the narrowed artery with plaque and balloon inflated so that plaque gets compressed, stent expanded, the smooth blood flow is restored. So next is angiography. So angiography, it is an imaging procedure using to contrast to visualize the arteries, identify the blockages and to guide intervention decisions. So it may be diagnostic only or performed with revascularization. So angiography may be separately reportable if it is truly diagnostic, not just road mapping and not previously performed. So here are some angiography codes which are mentioned. So 75600, it's a thoracic aortography without serial imaging. So in this there is a single plane imaging and only it gives a limited diagnostic detail. Whereas in 75605, it's a thoracic aortography with serial imaging. So there is an involvement of multiple images over time. There is a better flow assessment. 75625, abdominal aortography. So evaluates the abdominal aorta and the branches. 75630, abdominal aortography plus bilateral iliofemoral runoff. It includes the lower extremity arteries. It is very common for PAD workups. So these codes may apply with or without revascularization if diagnostic criteria are met. So coming to revascularization versus without revascularization. So what is with and without? So with revascularization, there is a angioplasty, there is a stent placement and atherectomy. If there is without revascularization, there is an only catheterization done and only diagnostic angiography. So this is the difference between with and without revascularization. And next is extremity angiography codes 75710. It's for angiography extremity unilateral. So imaging of one limb only. What is an example? Right leg angiogram, left arm angiogram. So use when only one extremity is studied. 75716 angiography extremity bilateral. So imaging of the both extremities here. Plus 75774. It's an add-on code. So it is used when additional angiography study is taken, separate vascular territory and different catheter position. So additional imaging performed after the catheter repositioning. So what are the other associated codes? So these are not routine. They require the documentation and criteria. So 76937 for vascular ultrasound guidance. So these are used for vascular access. It requires real-time ultrasound. It requires the patient documentation, permanent image saved and separate report. So it is not coded if ultrasound use is not clearly documented. And 37252 IVUS non-coronary initial vessel. So it includes the intravascular ultrasound. It is used to access the vessel diameter, plaque severity and stent sizing. 37253 IVUS non-coronary, each additional vessel. So it's an add-on to 37252. So IVUS is separately reportable when it is documented. And 77001 is a fluoroscopy code. It is bundled, so you have to never code this separately in a vascular procedures. So fluoroscopy is almost always bundled, so you do not code it separately. And next is lower extremities example. So this teaches how catheter placement plus angiography codes paired together. So abdominal aortography with runoff from one catheter position. So what does this mean? If a catheter stays in an abdominal aorta, so the contrast flows down into iliac arteries and the femoral arteries. So there is no catheter movement documented here. 36200 catheter placement aorta. So this is a type of non-selective catheter placement. So this is used when catheter remains in the aorta. This is the base catheter code. 75630 aorto-iliofemoral angiography. So it's an imaging of the abdominal aorta, iliac arteries and femoral arteries. So why 75710, 75716? These are not used here because imaging originates from the aortic injection. So this is not selective extremity catheterization. Therefore, 75630 is correct, but it is not separate extremity angiography codes. So if catheter stays in aorta, you have to assign aortography codes. If catheter stays in iliacofemoral artery, then you have to assign extremity angiography codes. So next procedure is pacemaker. So what is a pacemaker? It's a small battery powered medical device which is implanted under the skin, usually below the clavicle, that helps you to regulate the heart rate by sending the electrical impulses to the heart when it beats too slowly or irregularly. So now, what are the main components of a pacemaker system? Pulse generator, leads. So what is a pulse generator? It's a metal box placed under the skin. So it contains the battery which lasts 7 to 12 years. It contains electronic circuitry. So what is the function of a pulse generator? It generates the electrical impulses. It senses the heart's natural electrical activity and it decides when pacing is needed. So the second component is lead. So what are leads? Leads are also called as electrode. So these are the thin insulated wires connecting the generator to the heart. So what are the functions of leads? It senses the intrinsic heart activity. It delivers the electrical impulses to stimulate the contraction. So these leads, these electrodes, they are fixed by active fixation screw in the tip and passive fixation, the time tip. So what are the types of pacemakers? So based upon the chambers paced. So we have a single chamber pacemaker and also dual chamber pacemaker. So in single chamber pacemaker, it uses one lead. The lead is placed in either right atrium or right ventricle. So this is very commonly used for the chronic atrial fibrillation with slow ventricular response and also isolated AV block. Whereas in dual chamber pacemaker, it uses two leads. So leads are placed in both right atrium and right ventricle. So the advantage of using dual chamber pacemaker is it maintains the AV synchrony. It is more physiological heart rhythm. It generates more physiological heart rhythm. So what are the common indications of a dual chamber pacemaker? When there is a complete heart block, when there is a sick sinus syndrome with AV conduction issues, generally dual chamber pacemaker is inserted. And lead insertion and positioning. So how the venous access is done? So most commonly through the subclavian vein. So alternative veins are cephalic vein and internal jugular vein. So what is the path of the leads? Vein, superior vena cava and then right atrium and also into the right ventricle if there is a ventricular lead. So now how the pacemaker works? So if the heart rate drops below a programmed rate, so the pacemaker fires. If the heart beats normally, pacemaker remains silent. So this is called as a demand pacing. So what are the indications for pacemaker implantation? Symptomatic bradycardia and complete heartbeat if there is a sick sinus syndrome and also AV block type 2 and also post-MI condition defects. So MI post-MI means post-myocardial infarction defects. So pacemakers does not stop the fast rhythms. That's a defibrillator's job. So leads are always placed in the right heart chambers and also the generator is usually placed in the subcutaneous pocket. So modern pacemakers, these are always MRI conditional but not all. Next is implantation. So what is a pacemaker implantation? So the venous access is subclavian vein. So subclavian vein is punctured just below the clavicle. So alternatives if needed, it will be a cephalic vein cut down and also internal jugular vein. So subclavian access is quick but it carries a risk of pneumothorax. And how does the lead is inserted under the fluoroscopy? So under fluoroscopy, so what is fluoroscopy first? It is used to visualize the lead movement in a real time. So leads are always advanced through subclavian vein to SVC to right atrium to right ventricle. So pacemaker leads are always placed in the right-sided chambers. So next is pulse generator connection. So the pulse generator is connected to positional leads, is also placed in the subcutaneous pocket. And CPT course 33206 to 33208, they include the generator insertion, lead insertion as well as generator pocket creation. So now what is lead testing? So lead testing, it is performed before closing the pocket. Sensing, it does the lead detect intrinsic cardiac activity, capture threshold, minimum energy to cause the contraction and impetus. It checks the lead integrity. So if there are any poor values, it shows the reposition lead before the closure. Now what is the securing and closure? So in securing and closure, the leads are sutured to prevent the displacement. Generator pocket is closed in the layers and sterile dressing is applied. And next, implantable cardioverter defibrillator. So what makes an ICD different from a pacemaker? So pacemaker, it treats the slow heart rhythms. It gives the low energy pacing. Whereas ICD, it treats the life-threatening fast rhythms. It gives high energy shock split pacing and also it results in the ventricular tachycardia or fibrillation. So what are the ICD system components? ICD pulse generator, which is larger than a pacemaker, and defibrillation lead, which is very thicker, and shock coils. So what is a single chamber ICD? There is only one lead used and which is placed in the right ventricle. So this can pace the ventricle. It delivers shocks if ventricle or ventricle failure is detected. Whereas dual chamber ICD, in these two leads are used. So the defibrillation lead is inserted into right ventricle whereas pacing lead is inserted into the right atrium. So what is the advantage of this dual chamber ICD? For better rhythm discrimination. It maintains the AV synchrony if the pacing is needed. And defibrillation lead. So it is thicker than a pacemaker lead. It contains the shock coils. It is placed in a right ventricle, and also it delivers the high energy shocks for ventricular tachycardia as well as ventricular fibrillation. So ICD always treat fast, lethal rhythms but not slow rhythms alone. So how does it monitors and paces the function? So monitoring and pacing function. So an ICD can continuously monitor the heart rhythm. It can deliver ATP, anti-tachycardia pacing, which is a rapid pacing to terminate the VT, and also the backup bradycardia pacing if the heart rate becomes too slow. So this is why ICDs are sometimes called as smart pacemakers with shock capability. And then venous access for lead placement. So what are the veins which are accessed for placement of this ICD leads? So the common routes are subclavian vein, which is the most common, cephalic vein, and internal jugular vein. These are alternatives. So what is the path of a lead? First subclavian vein, then into SVC, and then right atrium to right ventricle. And here is a diagram which shows you the ICD generator as well as the leads and also the conduction system. So ICD generator, it is implanted subcutaneously without open, and it's a percutaneous approach, and leads, they travel through the veins into the heart, and there's a conduction system. This is the area where arrhythmias originate. So ICD senses the abnormal electrical activity in the ventricles and also it reacts immediately. So next is usage of modifiers and eliminating the denials. So PCI codes, these are vessel specific, and payers must know which coronary artery was treated and whether multiple services are truly distinct. So missing or incorrect modifiers gives the bundling edits, denials or downcoding. So what are the coronary artery modifiers? So these modifiers, they are appended to PCI CPT codes to specify the artery. So LC for left circumflex coronary artery, LD for left anterior descending coronary artery, LM for left main coronary artery, RC for right coronary artery, and RI for ramus intermedius coronary artery. So PCI coding, it allows one primary intervention per major coronary artery. So if multiple vessels are treated in the same session, each PCI code must carry the correct vessel modifier. And then next is modify 59, distinct procedural service. So 59 is used to show that two procedures are not bundled, they are separate and independent. So next is XC. XC is a separate encounter. So it is used when there is a different session on the same day. And XP, separate practitioner, different provider perform the service. XS, separate structure. So different vessel or anatomic site is involved. And XU, it's an unusual non-overlapping service. There is no overlap with the primary service. So in these cases, you have to assign the modifier XU. And next modifiers is laterality modifiers, LT and RT. So LT, left side, it is used when the procedure is performed on the left side, and right RT, so it is used when the procedure is performed on the right side. And modifier KX, this is for medical policy requirements met. So this is used when a payer requires proof of medical necessity, and this is very common in pacemaker or ICD primary prevention cases. So it indicates patient meets coverage criteria and also the documentation supports indication. So ICD implanted for primary prevention in cardiomyopathy. So you have to assign the CPT code plus KX modifier. And modifier QO, it's for investigational clinical service. So when QO is used, when the procedure is performed under CMS approved clinical trials, and most commonly for leadless pacemaker procedures, new or investigational cardiac devices. And here is a note. So QO modifier, this must be always reported with Z00.6 whenever it is applicable, because Z00.6 code, it describes encounter for examination for normal comparison and also the control in clinical research program. So modify 57, decision for surgery. So what it indicates, an E&M visit resulted in a decision to perform surgery. So when to use pacemaker or ICD implantation is planned for the same day or next day after consultation or admission. For example, cardiology consult is done and provider decided for ICD next day. So you have to report the particular E&M code with modifier 57. So procedure code reported separately. So do not confuse 57 and 25. So 57 is for decision for surgery, whereas 25, it's a significant separately identifiable E&M service on the same day. So this is about the CPT coding guidelines for cardiovascular system and also the modifiers used within the system. So this is for today. I hope the session has helped you. So in the next session, you are going to learn the CPT coding guidelines related to the surgery section of digestive system. Thank you.